Hey everyone, and welcome to another episode of Finch Med. Today we're talking about diabetic ketoacidosis as part of our endocrine emergency series. This is such an interesting problem because it brings biochemistry to the bedside and something we see almost every day. There are three things we do to treat somebody who has DKA. Number one, we tank them up with some IV fluids. Number two, we replete their electrolytes. And number three, when they're good and ready, we give them some insulin. Patients who truly come in DKA are functionally depleted of insulin, and they have way too much counter-regulatory hormone. Counter-regulatory hormones include glucagon, cortisol, and epi. Now, where are all these hormones acting? The first place they're acting is in the adipose tissue. If you'll recall, in adipose tissue, we have triacylglycerols, which are a glycerol backbone with 3 fatty acids attached. These undergo lipolysis to form free fatty acids. Now, the enzyme that mediates the lipolysis is called hormone-sensitive lipase, HSL. As the name implies, this is hormone-sensitive to insulin and the counter-regulatory hormones. Specifically, in a situation like DKA where there is decreased insulin and an abundance of the counter-regulatory hormones, HSL is more active, and so you see more lipolysis and therefore more free fatty acid generation. This is a bad thing because the free fatty acids serve as a substrate for the production of ketones later. The free fatty acids travel from the adipose tissue to cells in the periphery using albumin as a carrier. Let's take a look in a cell. So the free fatty acids travel into the cytosol, and they need to go into the mitochondria because this is where beta oxidation takes place. But they can't go there by themselves. They need a carrier in the form of the carnitine shuttle. This is another place that insulin and the counter-regulatory hormones play a big role because the carnitine shuttle is actually mediated by malonyl-CoA, MCA. And malonyl-CoA itself is controlled by the amount of insulin and counter-regulatory hormones present. If there's more insulin, there's more malonyl-CoA, and when there's more malonyl-CoA, the shuttle shuts down, and free fatty acids cannot go into the mitochondria. In a situation like DKA where there is no insulin, we have an depletion of malonyl-CoA, and the free fatty acids are shuttled more easily into the mitochondria. Once they're in the mitochondria, the free fatty acids undergo beta oxidation. Now there's really two ketone bodies that are formed, acetoacetate and beta hydroxybutyrate. Beta hydroxybutyrate is the more abundant ketone. Acetoacetate is really what's found on urine ketone tests, which is interesting. The third place where insulin plays a role here is again related to the malonyl-CoA system in that malonyl-CoA helps package free fatty acids back into a form that can be transported to adipose tissue. So, in summary, when there's more insulin, you have more malonyl-CoA. Free fatty acids are then getting pushed back to adipose tissue, and they're not being transported into the mitochondria. There are two other things that I want to touch on before we move on. Number one is insulin receptors on the cell. And if you'll recall, this is how we move glucose from the blood into the cells. And number two are hydrogen ion, potassium exchange pumps. If you'll recall, it's hydrogen ions that are being moved into the cell and potassium that is being moved out. Now, this is being done so that it is isoelectric, positive for positive, and it is being done to maintain a normal pH. So in the setting of your acidemia, because of the ketoacidemia, you're bringing hydrogen ions into the cells, and the sacrifice you're making is that you're giving up potassium. I want to review these concepts in a slightly different way. So in DKA, we have a patient who has increased counterregulatory hormones and decreased insulin. And why is this the case? Why is this happening in this person? Well, it's your job to explain that, right? You have to figure out if this is an initial manifestation of type 1 diabetes. Is this a medication non-compliance issue? Or is this something totally different? For example, all of these patients are vasculopaths. Have you made sure that they're not having a myocardial infarction or stroke? Alternatively, is there some terrible infection somewhere that you have to dig and look for? For example, a pneumonia, urinary tract infection, mucor, appendicitis. So you have to explain, in addition to treating the DKA, why the DKA is present here today. But the actual DKA pathogenesis is really happening in two ways. Number one, we have our ketone formation, and this is happening by lipolysis, which forms the fatty acids, which go into cells in the mitochondria, transported by the carnitine shuttle, and form ketones. Now, it is these ketones which create the acidemia and create many symptoms of DKA, specifically the nausea, vomiting, abdominal pain, fast breathing. And it is this acidemia which causes the shunting of our potassium out of cells. On the other side of the equation, we have hyperglycemia, and this is secondary to the insulin receptors not having any insulin to push the glucose into the cells. Now, the main manifestation of this is an osmotic diuresis, and as this gets more serious, we start to see hypovolemic shock. And we see, therefore, acidemia occurring from the ketone and from poor perfusion from the hypovolemic shock. The osmotic diuresis is causing us to pee in huge quantities, and because we have all this potassium extracellularly now, we're also becoming total body depleted of our potassium. So now we are in hypovolemic shock, and we have an increase in the amount of counterregulatory hormones because of this, and the whole cycle starts again. So you see a positive feedback loop here. So let's review. We're now going to treat this patient. Again, the three things we do: we give them fluids. And why are we giving them fluids? Because we want to address this hypovolemic shock. This will help with the acidemia, and it will address the osmotic diuresis. Number two, we're going to replete the electrolytes, because we're becoming depleted in our total body potassium because of this diuresis and our acidemia. And this is really important because if you're too hypokalemic, you become prone to arrhythmia. And so this is probably the most dangerous aspect of DKA, is if you don't address the electrolyte imbalances. And the last thing is, how is the insulin working? So when you give a person insulin, you're blocking this pathway because you're now moving glucose into cells, which is going to decrease the osmotic diuresis. And number two, you're coming over here and blocking the lipolysis. Remember the hormone-sensitive lipase. So you are making it so there is fewer amounts of free fatty acids. Additionally, you are decreasing the ability of fatty acids to go into the mitochondria and become ketones, because remember that carnitine shuttle is also dependent on ketones. Let's move really quick back to our cellular diagram and cover those same concepts. So the glucose here is going to be moved into the cell by insulin. Insulin is going to shuttle potassium back into cells. Number three here, it is going to stop hormone-sensitive lipase from causing lipolysis and therefore decrease the substrate for ketogenesis, the free fatty acids. And number four, it's going to block the carnitine shuttle, making it so that the fatty acids can't go into the mitochondria. So these are the main reasons we do what we do and why we give IV fluids, electrolytes, and insulin. I hope this was helpful. Thank you so much for your time.